Hello, and we have begun. I know you can't see me back here. I hear everybody. It's one of the neat things when you're a surgeon, you learn to hear almost everything that's there. So today's topic, you might recall for those with, in the anatomy part of the program, this was the chapter that we had used. It was chapter 17 in Marib, as you can see here, hopefully. I better expand it so you can see it. Ruh-roh. I'll just get to the slideshow part just as easily. Doesn't really matter. We're going to begin. And so what we're going to discuss, so to speak, is this part. We'll begin to discuss really more of this is really the start of heart physiology. If you don't recall the anatomy, in some way, shape, or form, make an effort to review the anatomy. It would be pretty straightforward. The location of the vena cava, the aorta, the valves, because now it comes into play. Because really, even though we're not going to deal with this today, what we will start is dealing with this. And I have another announcement. I have had several students for a variety of very valid reasons who I'd listened to this, young man, since you were asking a test question, Joey. It's okay. Just smack him. I've at least several of our students in the class, for very valid reasons, have received my permission to take the test on another day, which is perfectly. And again, just like we did previously, sometimes when that happens, I feel compelled to offer that. If you don't feel you are prepared and would like, then I'm more than happy to find a way that you can take the test on Friday as opposed to Wednesday, whatever suits you. That's fine with me. I'll be giving a test in Wednesday. That's my plan to do that. Unless nobody shows up, then I'll lecture. But in that case, you'll be taking the test on Friday. You got the idea, everybody? Because I'm never. I may be a lot of things. I try not to be unfair. I have my faults. I'm not the greatest at certain things, but when it comes to try to be fair to you guys, I think that's something I try to excel at. I'm getting tired of talking over people. Thank you, everybody. Shechet Pravakasha. That's Hebrew for shut up, please. Pravakashas, please. That's all right. It's been a long day. When I get like this, it's been a long day. And not you guys. You guys were fine. Earlier. First year students drive. See, I used to have hair. You used to look like Sydney's hair. It was nice like that. Now, what you see is what you get. Moving on. So, without further ado, we're going to do the heart. So we're going to focus on the electrocardiogram today. I am fortunate to be surrounded by people with an EMT background who can assist me in this endeavor. I am delighted to say that. And I'm sure they'll be more than willing, with your encouragement, to assist. But let's review what there is about this. If you don't recall, the heart has three different kinds of really cells that are relatively similar in appearance, but don't do the same thing. You have cells that are probably dissimilar. Those are the framework cells. They're the construction material. They make the frame that we attach the heart muscle to, the valves to, etc. So they're structural elements. And then you have the predominant cell is certainly cardiac muscle. Vast majority of the system we're looking at is muscle. And powerful, strong, endurance-oriented muscle. And lastly, we have the conducting system, which, like the heart muscle, can pass electrical signals to one another, but unlike the heart muscle, does not contract. So we're doing something that is excitable and something that can convey a signal but does not contract. So there are similarities and there are differences. Is that what we're going to look at? The intrinsic cardiac conduction system. And because of that, we have because we have the gap junctions, it facilitates the movement of the signal very readily. And wherever it starts, whether the signal starts where it's supposed to be, or whether it starts somewhere else, it will carry through sequentially all the rest of the cells until all of them contract. It will carry that signal without fail to do that, assuming there's no other structural or blood vessel, like someone that had a previous heart attack, et cetera, et cetera. So it's a network of non-contractile, and when they say autorhythmic, if you remember what resting membranes are like, and you'll see some illustrations about this when we get to the physiology. The idea of being autorhythmic is that they don't have a steady resting membrane potential. They're leaky. Okay, so we have channels that are going to be leaking in, as my recollection serves me. We're going to have sodium influx as soon as it reaches its nadir, the bottom of its resting membrane potential, it starts to leak. And that form of leaking is going to permit it to become closer and closer and reach threshold at a very predictable rate. So not only are they autorhythmic, they basically set the pattern based on how autorhythmic, in other words, how fast or how leaky they are, would be the way to describe autorhythmic cells. They initiate and distribute impulses to coordinate the polarization and contraction of the heart. Again, words matter. Electrical events precede mechanical events. We spent a whole time about that in the neuromuscular junction. Electrical events preceded chemical events, and now mechanical events. So what happens when we see depolarization and repolarization, it's an electrical event. When we see contractions, which we call systole, and relaxation diastole, which are the top and bottom numbers of your blood pressure, just in case you weren't aware of that. I was pretty much sure everybody is. That basically signifies systole means contraction, diastole means relaxation. So electrical events are going to precede mechanical events, a consistent pattern we see physiologically throughout the system. So these cells are unstable. They have pacemaker potentials, or if you will, pre-potentials until they reach threshold. So potassium channels are closed, but these slow sodium channels are open. And as I was telling you, that effectively generates the leakiness, as it were. So once that is initiated, depolarization occurs. And what you will see, what maintains this, interestingly enough, we have sodium leaking in. And yes, what happens at depolarization, we have calcium channels open. And here we get a significant difference between nerve and muscle. Here you're going to see calcium channels opening at or around minus 40 millivolts, and there's a huge influx of calcium leading to the rise. So rather than sodium influx, because the sodium has created the leakiness, it's this potassium. And what's interesting, you're going to see that potassium is not quite as sharp of a spike. We look at the electrics of it, and repolarization again is potassium channels opening, allowing the efflux or outflow of potassium as the cell becomes more negative. Voila, you get a different pattern. You'll see it right away. That's different. So you can see at the bottom where the fancy word, the nadir, you have the nadir and the apogee. It's like from blocking shots at basketball. Just ignore me. Okay. So as you can see, once it reaches its bottom, its resting potential, whatever they have on this chart, it immediately starts to rise, reaches it, and then you can see the action potential, and you can see the spike is a little bit less pointed. If you want to, abrupt might be a better word. What's interesting about calcium channels, they tend to prolong that contraction. And think of that as really, when you think of how thorough the heart is in pumping, it's more of a squeeze. So that contraction is a bit more prolonged to thoroughly squeeze out the blood. The whole idea of the heart is the ultimate efficiency muscle. Endurance and efficiency. Every beat the same, every beat maximum, you're getting what we call optimum, or rather optimal ejection fraction. The amount that we're ejecting is consistent, and it's sufficient to drive our circulation in the appropriate way. That's the nature of that heart. And I mean, you got to do what you got to do with regard to that. Like I said, that's, as I was commenting earlier, I'm good for a while doing the treadmill and doing the cardio, and now then I'm bad for a while. And now after entirely too much partying vis-a-vis my daughter's wedding and events there, it's time to get back on the path once again. Hey, was good while it lasted. And they're just showing it to you. Okay, so enough of the electrics. Now we'll look at the system. This is the system that your electrocardiogram is based on. Okay, you're going to see a very useful graphic about it. This is the sequence of events. The pacemaker cells pass impulses in the following order across the heart in approximately 0.22 seconds. Remember, your heart beats more rapidly than once a second every second of your lifetime, but it takes such a small amount of time comparatively. So the heart does really well. What that means, you have a lot of reserve if you have to accelerate your heartbeat. And you're going to see that is based on something which we may or may not get to today, called the absolute refractory period. Just as we started to look at in nerves, the heart, roughly for a quarter of a second, is refractory. It's absolutely refractory. It cannot generate another beat. Just cannot do it. So you do have a maximum heart rate. No matter what the machines in the gym may say, or some device you're wearing on your finger or on your wrist, there is a maximum heartbeat. It's about 233 beats per minute. That's because of the absolute refractory period. Just try to be aware of those kinds of things, because you hear stuff and it's like, oh God, people aren't as bright as they think. The pacemaker is known as the sinoatrial node. Okay, it carries the signal, but effectively is fairly slowly and deliberately to the atrioventricular node. The SA node is located in the right atrium. The AV node, or atrioventricular node, is located in the interatrial septum. That combination is effectively the rate-determining step from good old chemistry of how rapid this heart rate is. You don't have as many viable channels. There's just not an abundance of passageways, an abundance of fibers in this area. It is intentionally delayed. And why it is delayed, when you get to the physiology of the heart, it allows the atria basically only compress ever so slightly, and their whole purpose, because most of the blood in them is already gone. It's in there transiently. When we look at the cardiac cycle, the blood's coming into the atria and immediately goes into the ventricles, because those valves, the atrioventricular valves, the tricuspid and bicuspid valves, are open. Okay? The semilunar valves, the aortic and pulmonary semilunar valves, are closed. So at rest, whether you're lying down, sitting, whatever you're doing right now, is filling. Okay? When the atria contract, they contract relatively slowly, and that's because of the AV node and the fact that by intent it is slower, and it allows the atria to contract sufficiently to effectively, and the term I always use is top off the tank. That thing when you go to the gas station and say, don't top it off, go to Costco, my God, they'll yell at you. Go to Sam's, don't top off your tank. Don't tell that to the heart. The heart, roughly that last 20% of filling comes from the atria contracting and maximally filling the ventricles, so you can have the optimal number, the desired number, called the ejection fraction, the appropriate and maximum amount. It's an efficiency weapon. It's all about it. That's what this guy does, the heart. Very, very efficient in what it does. From there, the signal now is extraordinarily rapid. Okay, because after that, that part of the heartbeat takes probably, maybe 0.12 to 0.20 of that 0.22 seconds. The rest of it, the atrioventricular bundle, goes rapidly through the septum, or the divide in the interatrial, and then into the interventricular area, divides into bundle branches, right or left. They go down to the apex of the heart and swing about forward, backward, laterally, sort of three-dimensionally encircling the heart, and the apex of the heart contracts in the direction of the base, sort of from the apex pointing down, sort of left and lower, and pointing up, right, toward the right shoulder, and squeezes up and out. You recall we talked about this in anatomy, and very, very rapidly. So the rest of the portion, we're talking about under a tenth of a second, surely, most of the time. If you look at sort of the average EKG tracing, probably less than a tenth of a second for all that blood to be ejected. And then we take a break for a quarter of a second, and the heart gets ready to pump when it's told to, based pretty much on how healthy you are. So the SA node, known as the pacemaker. Why? Because it is inherently the least stable or the most autorhythmic of any area. So what happens to that is that it's the first one to basically reach threshold, and it governs the rest. So normally it's approximately, on average, 75 beats per minute. Depolarizes faster than any other part of the myocardium. So the inherent rate of the heart, as you can see, is over 100 times a minute. And then the extrinsic factors are your autonomic nervous system. That is your vagus nerve. Again, it's a governor. Our systems, just like the cell cycle, are governed. Basically, our heart would be trying to go too fast. The healthier we are, the more it's governed. So healthy individuals, typically your heart rate is between 60 and 80. I was shocked. Now, here was mine, having not done a whole lot of exercise for a while, was about 75. Not considering that's nearly my age, I thought I was doing okay. Just say it. Ignore all those carbs I was eating like candy. Just say it. But what that resting heart rate does is that, if you recall what maximum heart rate is your reserve. So resting heart rate, you can ask anybody in a clinical field, is a wonderful measure of your health. Now, for you folks, it should be all fine. It should be between 60 and 80. For those of you who are athletic, training, just pay attention to your fitness, it may even be a little less than that. That just means more reserve. If you're a little less careful with things that you do, or you have some bad habits, not asking anybody to disclose anything, maybe you're creeping into that 80, 100. Not good. When I first started doing this lecture, when I started doing AP2, not here, but probably the earliest place I did it was CCAC. That's why I don't use myself as a subject. Remember, I weighed about 250 and was smoking 2 packs of cigarettes a day and eating anything that I possibly could get my hands on. Okay? I think my resting heart rate is 106. Well, that's a heart attack looking to happen. And I think I was 51, 52 at the time, 2002. Not so healthy. And there's one reason why I'm healthy today. Patty Graves, my wife, who has threatened me with significant bodily harm if I don't stay healthy and keep this promise of teaching for another 15 years or else. And my kids are trying to get me to retire. Oh, now that Patty's mom is gone, God bless her, when are you going to sell the house, retire, and move to Florida? Never. My students would miss me. For sure. Probably my turn. So the inherent rate is governed. The impulse then spreads from the atria to the AV node, as we talked about. Well, I talked about. So in the inferior interatrial septum, there's a delay of 1/10 of a second. Fibers are smaller, fewer gap junctions. It's anatomical. The atria contract prior to ventricular contraction. It has its own rate. It can take over. The trouble is 50 beats per minute. It's not very good. It's called a junctional or nodal, N-O-D-A-L rhythm. Not very good. We see this in people who have had previous heart attacks. Trouble is, you can't you'd have a tough time walking from here back to the atrium and getting a seat at 50 beats per minute. So you could sustain life but do very, very little activity with regard to that. It's just the way it is. In the absence of the SA node, and people have this, and the solution typically eventually is for them to have a pacemaker implanted. If you did not know, years ago, when people had arrhythmias, we didn't quite have the pacemaker technology that we have today. And they used a lot of and the medicines were very harsh, had a lot of side effects. And then we made the transition, and medically over the last, let's say 20, 25 years with increase in technology, to have pacemaker implantation. Okay, and the pacemaker is interesting because understand the only connections you're going to see shortly between the atria and the ventricles is that bundle. Okay. That interventricular bundle, or bundle of His, capital H-I-S, the proper name. That's the only connection. And if that's not there, so when you insert a pacemaker, you have to implant leads in the atria and leads in the ventricle and rely on and basically artificially create that relationship. So it's a unique system in that regard. So here's the AV bundle. As you can see, the proper name we used to call it the bundle of His. Superior interventricular septum, the only connection between the atria and the ventricles. Otherwise, no gap junctions. So again, pacemakers have to be that way. There have been problems with pacemakers over the years. At least in my opinion, the technology continues to improve. Unfortunately, some people have had to have them removed. It's. I think we're in an age where technologically that we're going to refine those things. I'm optimistic. And then you have the bundle branches, which are the pathways to the right and the left, carrying the impulses toward the apex, the direction of flow that are there. And then finally, as you can see here, the subend, it used to be called the Purkinje fibers, the term and now they call it the subendocardial conducting network. This is the pathway from the interventricular system along the walls, like I said, posteriorly, anteriorly, laterally, more so on the left. Okay, it has its own rate. Unfortunately, 30 beats per minute, you can't sustain life. So when we have a rhythm like that, eventually what's going to happen is that kind of irregular rhythm, series of heartbeats, is unfortunately going to lead finally to something tragic. Okay, we're going to end up with insufficient blood flow to the area. You're going to get some type of pathological rhythm, and unless you're fortunate, you may not respond. We'll get more into that in a second. So the process from initiation of the SA node to the complete contraction, approximately 0.22 seconds. So a lot of this discussion is about the arrhythmias, and we see some of them. And again, like I said, we have folks here. We're fortunate to have folks here who have the kind of training and they're EMTs. But fortunately, we have the technology available in schools, in malls, in a variety of buildings. We have AED technology, the automatic electronic defibrillators. So even the layperson with no training at all, if they have some idea of what to do, and it's almost self-explanatory, the machine does it itself. I mean, so you're basically able to identify what we call a rhythm that has to be shocked or converted. Okay, and understand. So and maybe you were acquainted with it for those who are EMTs and in the profession. Years ago, the reason why we have switched to these defibrillators and why that is superior was studied. The original studies were done in the state of Washington, and they found that if there was a witnessed arrest, a witness cardiac arrest, you're walking and see somebody go, "Oh my God," falls down, witness arrest, and you knew how to do CPR, and you initiated CPR. The odds were 5 to 15% of those people would die in any event. So you're looking at 85. You're saving 85 to 95%. Which is a great number. They found out if you had the AED technology and you could defibrillate under the same circumstances, the numbers went from only 1 to 5%. So you're saving 95 to 99%. So the whole idea is to shock out the rhythm. And you see some of the terminology as I backtrack. It's tough for me sitting down here to be able to do that. Heaven forbid I'd actually have to get up. Oh my God. Where did I see it? Rhythms. Okay. So when we talk about rhythm and they'll talk about things, you're going to see terms, and you got to be careful again with terminology appropriately. How you in the field might refer to it may be different how I refer to it. So I have to go by what is sort of textbooky, if you know what I mean. So when you hear the term sinus rhythm, you will see all that means, okay, is that you're going to see we're going to have a P wave followed by a QRS. We have the atria, and then we have the ventricles. It doesn't say anything else. Sometimes that's the goal of defibrillating. When you hear the term normal sinus rhythm, it implies how rapidly the beats are. And if they're between 60 and 100, that is a normal. So the normal is the rate. The sinus rhythm means that the SA node is the one leading the fray. You're back at the original pacemaker doing its thing. So understand there's different terminology when we start to get to some of the electrocardiographic findings. It's a different view up here. Just one effing time laugh. You can go through all those walls. I can go through them. I'm not going to read them to you at all. Voila. So arrhythmias, irregular heart rhythms, uncoordinated events between the atria and the ventricles, and the ones that are the largest single problems are fibrillations. When it's fibrillating, it's contracting but not really doing a whole lot. It's contracting so rapidly, it doesn't permit appropriate filling and it doesn't permit appropriate pumping. And if it's in the atria, it's going to lead to the one in the ventricle. And in the ventricle, you're going to see a classic pattern that this PowerPoint will show you. And once that occurs, eventually that is doomed because it's going to go flatline. Because now you're not getting a sufficient amount of blood flow to do anything, and the heart will be effectively unable to feed itself, and it will stop. And if you don't do something rapidly, then you're in trouble. Pure as that. So I think maybe the important point, I mean, how many, you know who you are, but I think most of you probably have relatively recent CPR training. I mean, EMTs, obviously, but most of you have had it within the last couple of years. Yes? No? Yeah? More or less. During the time you've been here at school, it's probably a good idea to keep getting that stuff done. I mean, I haven't certified because physically it would be hard for me. I would still attempt it, but I haven't had CPR. I don't think it's changed any dramatically over the last X number of years. But when you're in the hospital and you're operating, you're obligated to have that. That's part of those little. They just send you, your CPR certification expires. Get it done within the next, 2 months, or else you're not operating here, which is powerful inducement. So when we look at fibrillation, is that so it doesn't pump, and eventually you're going to limit the circulation. If it starts in the atria, it's going to go to the ventricles. If it starts in the ventricles, it's going to lead to insufficient blood supply. And then now, if we don't get that done, so what does defibrillation do? It's a reset. You're administering a substantial charge to do one thing. Because of the absolute refractory period, if you fire all the cells at once, they will all undergo the absolute refractory period. And if you're fortunate and that pacemaker has not been somehow permanently damaged or even temporarily damaged, it will take over. It will resume, and hopefully you will get a sinus rhythm from the SA node going through the AV node, going into the ventricles, in whatever shape or form it is. So that's kind of the idea. So they call it clean slate, whatever you want to call it. And hopefully, maybe you have to do it once, maybe you have to do it twice. I can remember seeing the first day I went I hadn't been in the emergency room. It's like my first day of residency, and the gal who I ended up marrying, I'm picking her up, and she was an ER nurse. She was like assistant head nurse of the ER, and they were just rebuilding the ER in this inner city hospital that we were moving to a new one. And I'm getting there like 11:30, shift change. She was working 3 to 11. And all of a sudden, and the next thing I hear is they call the code. And the next thing she jumps on top of some person on a stretcher and just nails they did the precordial thump. This little girl weighed 100 pounds soaking wet. Wham, like that, and starts pumping away. And the thing just went wacky after that. It's kind of, I remember it acutely like it was yesterday. It's very, very interesting. And I learned a lot about that from her. And any of you going into a medical field, whether you're a physician assistant or in medical school or in some way, shape, or form, listen to the nurses. They've been there. They know what they're doing. You can learn a lot. Don't be, I'm trying to think of the right word, anal orifice. Think that you're smarter. You might be smarter, but they have a whole lot of experience. They will, and if you're good to them, they will stop you from that effing up thing. Because they'll say, I'm telling you, God's honest truth. Treat people nicely, and they'll treat you nicely back. Yeah, shocked. Nobody contacted me. So the SA node may cause an irregular focus. We call it an ectopic focus, meaning it's not working. And so we have to rely on that AV node. And you can see that 40 to 60. So we call it a nodal, capital NODAL, or junctional rhythm. And then and these are not uncommon at all, extrasystoles. Okay, premature contractions or ectopic beats. And probably the one thing we see a lot of is caffeine. So you're having one of those days where you're on your 16th cup of coffee. It's one of those days you just can't, you can't function. And believe me, if you're in a medical field, there's a lot of days like that where we were living on caffeine and cigarettes. And so, not unusual to feel those. Just feel the pulse and a beat. Well, sometimes you'll feel a misbeat. Sometimes you'll feel a regular beat. They're not that unusual. If they're only sporadic and there's not really a pattern, I wouldn't get overly excited about it, comparatively speaking. I mean, if it's you, I mean, you always have the option of talking with you. Don't try to feel it yourself. Go to whoever your family physician is. If they feel a referral for a cardiologist appropriate, you do it. Okay. Sometimes it turns out to be nothing at all. But those are just the kind of things that are there. So the heart, because of that irregular beat, it's longer to fill. The next contraction has got a larger volume. And typically, I mean, it's the first thing we would look for would be probably, excessive amount of caffeine usage. We see with energy drinks now more than anything else. I think would be a fair way to describe it. So when it goes through the AV node, okay, there's a degree of blocking, and sometimes it's not. Classically, we hear the terms primary, first degree, second degree, and third degree heart block. A first degree block isn't really a block, it's just slow getting through. A second degree block, and you'll see an example of one here, one beat might get through, but another beat won't. So you might have 2 to 1 or 3 to 1 blocks. Maybe every other beat might get through, every third beat might get through. Those are certainly not good, nothing desirable about that. And a total or complete heart block would be a third degree block. And that would be replaced by that nodal rhythm, or that junctional rhythm. And again, so if that AV node is defective, it may cause a few impulses or no impulses reach the ventricles. The ventricles then beat at their own rate, which is, again, 30-ish. Can't maintain adequate circulation, and now you have to basically recouple the structures that are there. In the meantime, those areas of inadequate circulation are also going to predispose you to have arrhythmias or irregular beats or irregular electrocardiographic things. And so everything else plays a role. This is more the straight physiology. I tend to do this more in lab. We're probably going to do this in lab just in the interest of time, looking at acceleratory and inhibitory, looking at basically going into the physiology behind it between, yes, those things again, voltage gated sodium channels. I know. Aren't you sick of hearing about those? I know I would be. All this kind of stuff. And the whole ball game, I'm not doing this, I'm just going to show you. I want to get to the cardiogram. The whole ball game eventually is going to be when we finally get to here. We'll go through that today, and then we'll have somebody volunteer. We'll go through all these events. The whole ball game is that slide. That's the slide that really gives you an idea where we can marry the electrocardiogram, filling times, pressures, and all of those things, heart sounds, all of those come together. That's a really neat chart to be able to use. And I feel that sometimes that a really good illustration is worth its weight in gold, so to speak. So let me back up and get you to this. So what is a cardiogram? You're making me look bad. Thank you. I have cooked this up for you. This site's been around forever. I've only been using it for like 20 years. They keep updating it. It doesn't change. It's called it's not hard to find. ecglibrary.com. And what it does is it kind of tells you what's a cardiogram. So effectively, you're measuring action potentials, and you do so by a series of what we call leads. We're just going to do a basic one here. I'll show you. There's effectively, when we see a typical cardiogram that we'll look at, we'll show you. But what's nice about this is you can find what myocardial infarctions, heart attacks look like, hypertrophy, mitral stenosis, pacemakers, etc., etc. You can see, and they'll give you some of the little clues. If you're ever stuck for reading them and you're in a clinical environment, that's good. So what effectively is this? And if you take a look at the electrical axis, we're going to look at these. And I didn't know this until, even as a student, I hadn't been told about this. And I'm doing that rotation I told you about down in Virginia. And and this intern's getting out a little spiral notebook, and he's looking at this. We just got in a cardiogram, and a guy was admitted, and he goes, "Oh," I said, "What are you looking at?" He goes, "I'm looking at the axis of the heart." And what he was able to see, normally you get typically a thing called a 12-lead EKG, and by looking at a couple of the leads, you're able to immediately tell. And we talk about positive, and I'll show it to you if it's going in a positive direction. Basically, what the electrical axis of the heart. Think of it. When you put in the classic, we would have limb leads. Now we just have pad here, pad here, pad here. Okay, you have those four, and they take the place of right arm, right leg, left leg. And then in a 12 one, you have what are called the precordial lead, and that's when you palpate various structures, interspaces, the nipple line, against the sternum, the far wall line. And I know some of you folks do it. Frankie was telling me you do these. So you do the palpation and put these on, and you run a tracing. By looking at those leads, effectively, the difference between the leads, not so much the precordial leads, but the limb leads, you're making a series of triangles. Basically what you're reading. And those triangles give you, it's almost like you're looking at the electrical impulses from this angle, forwards, backwards. You kind of get the idea without getting into an elaborate explanation. And so if you're going to see when they point out here, if lead 1 and what's called AVF, there's leads, the regular leads there are 1, 2, 3, AVR, AVL, and AVF. You'll see that in a second. If they're both positive, meaning the QRS complex, that big spike going upward, is going upward, then it gives you an idea what's going on. So using leads 1 and AVF, the axis can be calculated. So if the axis is in the left quadrant, take your second glance at lead 2, and they're telling you about it. So if it's normal, if both 1 and AVF are positive, that means the axis of the heart is where it's supposed to be, sort of in that, looking at left-sided and lower, where the maximum impulse is. And immediately you get a clue as to some clinical conditions. If it's on the right, it tells you something. If it's up here, what's called northwest territory, if it's in the left. And you can scroll down and see, like for instance, what would be an obvious point of deviation? Up here, what they call no man's land, where you have, and you can see when you talk about northwest territory, rather than being positive, they're negative. Emphysema. Well, here's something else that you might not even think of: lead transposition. Go back and check to make sure you put the leads on in the right place. I mean, it's the obvious one, so to speak. It's almost like this. And you can see the causes of right and causes of left. And here was this young intern showing me this, and I'm totally unaware of it and furiously taking notes. Don't know why, but I was. So as we go back, and like I said, you take a look at this thing. I found it really helpful. And here you have the normal electrocardiogram. Now, when you're doing it, Frankie, you doing a standard tracing? Has it got the scribe and the papers moving, or you just get a printout? It's live. I mean, so it's like. Okay, so if you're like me, and when they have to do a procedure on me, generally I have to get a chest X-ray and EKG if they're going to put me under anesthesia for any reason. And I mean, recently I had it when I had prostate procedure done a couple of years ago. And you get in there and they put and they just know what they're doing, bang, 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 and they run a strip. And you can tell right away. I mean, I can tell right away with mine. It looks like this. So classically, if you watch TV and you see the monitor, you go in the hospital and see the monitor. Typically, it's on either lead 1 or lead 2. Those are pretty standard. And you can see. So let's see. Here's lead 1, lead 2, lead 3, blah 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 blah. However, they're doing these things. And what you do, these squares all represent 5 squares are 0.25 of a second. Okay, so I beg your pardon. So each of these squares, so to speak, you have here, 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 here. So we count them. We're looking at something normal. So and I generally go from peak to peak because it's easier to read. So if you take a look at this, 1, 2, 3, 4, 5. It was all 5 of these. Each one of these would represent roughly, so it's 25 of those little millimeter squares a second. I know that this beat is occupying about 20. I realize that's less than a second. So I mean, I know the rate is not overly fast or not. And you just learn over time. You can do the math out But people who look at these quickly can tell you the rate right away. That's kind of the way they do it. And we look for certain landmarks. So you're going to see P wave, QRS, T wave. We look closely at that interval. You want it to be 3 to 5 squares. Each one of those squares is about 0.04 seconds. So 3 of them would be 0.12, 5 would be 0.20. That's kind of, you want that interval between the P wave and the QRS to be roughly that. So it's P, QRS, T, whatever they're doing is a different thing. P, QRS, T, and you want them to be identical. And so that you're looking at, because the rate is between 60 and 100, and every time you have a P wave, a QRS follows it, you get a T wave, that's a normal sinus rhythm. We want to start looking for stuff that's irregular. I'll show you some examples. So those are the things. So here, you have, and here's AVR, AVL, and AVF that you're seeing over here. And then the precordial leads V1, 2, 3, 4, 5, and 6. And by putting them over certain structures, you're able to look specifically, and people are very trained. There's good news. If you know what you're doing, you really get a lot of information. We don't use them as much anymore because we have more sophisticated scan. We still run them because that's what's usual, customary, and reasonable. In other words, that's what you're supposed to do for some 73-year-old guys going in and having his prostate, worked on. Because you're supposed to have an EKG because we don't want anything bad to happen on the table. The reality is I had one of these done, and all of a sudden, and I nearly flipped out because, you get your My UPMC or your My HN, your chart, and it says, evidence of, it says no different from last time we did the test, and then evidence of old myocardial infarction, meaning a heart attack. And I had a WTF moment with my family doctor. I said, WTF are you talking about? He goes, Lou, settle down. You're going to have one. He said, the problem with these now, they're read electronically. It's like AI reading them. And they'll come up with this stuff where there's no significant difference between last time, and then all of a sudden they'll give you something like off the wall. He says, you didn't have a heart attack or anything like this. That's why they don't like them. He said, years ago, they were always hand read, or they were read by individuals rather than by machines. So we're seeing a lot more of that. But now they're relying more on scans and other more sophisticated technology. Read that, it makes the hospital more money to be able to. Let's be clear. So you all get the idea. So give this a look or a look-see, and you might find something that's relatively interesting. Back to the PowerPoint we go. We're almost there. I know you're sick and tired of me anyway. I know I am. Just saying. Show up here. Thank you. So I say EKG. That's the way I learned cardio with a hard K from the German rather than C, whatever floats your boat. So all the action potentials at a given time, not a single tracing. The 12 lead is the one we use most typically. The events that you should know. The P wave, that first wave, signifies, again, it's electrical, the depolarization of the SA node and to the atrium. The QRS complex, starting with the Q, typically going slightly down, the R going up, and the S maybe even overshooting down a little bit. So we call it the QRS, is ventricular depolarization and atrial repolarization. The depolarization of the ventricle is so much of a bigger event, it obscures the atria's depolarization. You can't really see the atrial depolarization, it's just in there. The T wave, and again, ventricles are large, we can easily see ventricular repolarization. So we look at two big areas, the interval between the P and the R, because if there's going to be a block, that's where it's going to be. And the interval between the S and the T, or the Q and the T, because we're looking at the events of the ventricular myocardium and the whole idea of depolarization through ventricular repolarization. That's an area we look for irregularities a lot. They signal either acute or previous damage to the ventricles, and usually that means an older heart attack or insufficient circulation. Something ain't good that's going on. Be the best way to describe it. So you're going to see, when you see things like this, it's a little scary. That's typically what it looks like. I would have something like that, and they just put on those things and hook them up to the machine, tell you not to move, and get a couple of tracing and say, oh, that's a good one, and boom. off it goes. So you can see, we look for that PR interval. Again, this one has 4 of those little squares, let's say. So that's what you want. You want to have something which is going to show the depolarization, and it's going to get through that in what is considered normal. Then you're going to see that massive, almost an inversion going upwards of the QRS complex. And then the ST segment should be relatively fat. If it's elevated, going from here and then to here, or going straight to here, or depressed, going that way, that's a problem. ST elevation or depression usually signals damage to the ventricular myocardium, and that's a bad thing. And they summarize these for you. So, problems that can enlarge R waves. Typically, when that R wave that you saw before, that big spike, is unusually high, typically it points to ventricular hypertrophy, an enlarged heart. Where do enlarged hearts come from? Almost all it could be some primary damage to the myocardium, something bad like that, but most often high blood pressure. Simple explanation. High blood pressure means, particularly that bottom number, those blood vessels are taut. Your heart has to work hard to open them up and allow them to rebound. That's the way it works. And if your heart has to, it's like any muscle, it's being overused, it gets muscle bound. And eventually, just like we learned about muscles, now it's harder to generate this type of force that it needs over time. So enlarged heart, when we would see in the old days, we'd see a heart shadow on an x-ray. If it was over a certain amount proportionally to the size of that lung on the left side, you're like going, oh boy, this is trouble. Because we get, signs of cardiac enlargement, signs of cardiac hypertrophy or cardiomegaly, which means a large heart. Not good. So enlarged R waves, ST elevated or depressed, typically ischemia. Ischemia means inadequate blood supply. And when there's ischemia, sooner or later, there's going to be a heart attack. It just is. So QT reveals a repolarization abnormality, maybe the risk of additional. And so this is the typical normal sign. And they have like 4 of these, and they're instructive. So here, count the squares. You got about 17 or 18. That's about 75 beats per minute. That's average. That's desirable. So, for all your soccer playing, you would expect somebody who's running around a lot like that probably to have their heart rate a bit lower. And in general, young people, and particularly well-trained athletes, they have a pretty good amount of reserve that are there. So that's the normal sinus rhythm. So you have P wave, QRS, T wave, little break, P wave, QRS, T wave. Nothing unusual. If you look at the squares between here, maybe there's 3. Here, the T wave, there's no unusual elevation or depression. All good. Junctional or nodal rhythm. The SA node not working. Look at the amount of squares. 1, 2, 3, 4, 5. You have about 33, 34 little squares. That's way over a second. That's really slow. And he said, there's not a whole lot, and there's, no P waves here, whatsoever. So this is almost, you would even consider this to be a full-scale heart block as well as a junctional rhythm. There are no P waves whatsoever causing this. We're relying on the AV node to do everything. You can see the irregularity of it. You can see a certain amount of depression here as compared to the other views. It's not good. Here's one of those heart blocks. First of all, you can see the QRS are pretty darn small. And so look at it. You have a P wave, QRS, T wave, ignoring the size. And then you have P wave, nothing. P wave, QRS, T wave, P wave, nothing. 2-to-1 block. Okay. So they call it a second-degree block. 2 P waves for each QRS. And lastly, most famously, this is VFib, ventricular fibrillation. The so-called bag of worms. That's the analogy they always gave you. It's like you're going fishing and you went to the bait store and you got dirt, or you went out and scooped up dirt and you had a bag of worms you were going to use for bait. Not that I would fish. Like fish, but I don't like catching fish. It's all right. I'm not that hunting and fishing guy. My idea of outdoors, again, is golf course. Golf cart, lovely beverage. We're good. But so effectively, it's almost like in that old paper bag, you can feel it moving around irregularly. That was the analogy. I have felt. I gotta share the anecdote because I always do. When we learned about this, and I know it's horrible. I'm sorry, Maddie. We did vivisections of dogs. That was what you did in medical school back 50 years ago. We quote sacrificed animals. And one of the things that we did, unfortunately, in sacrificing these animals to learn was doing things that generated these abnormal rhythms. So I'm sorry to be so coincidental with things like that. But it's true. And it was horrible. And it's interesting. We each took a turn being in charge of the experiment. And so when it was my experiment, I had 4 other 5 guys. It was like you're the captain, like you're the chief surgeon. You're going to be the recorder. You're going to handle all the data gathering. We had like a physiograph, kind of like would think of something like this, but less electronic, more based on the old style lie detectors. And someone else is going to be doing the operating, and someone else is going to be handling the medications, et cetera, et cetera. And I said, some poor animal is going to give its life for us to learn something. We are going to learn something, everybody. So it was very, very difficult. Thankfully, they don't do this now. I'm sure. It's been a long time, but I can't tell you how troubling that a day that was for all of us. And so that's what I have to share with you about that. So we like to do these so you can see one. So I'm going to need a volunteer, and I'll show it to you. So let me conclude this part, and let me conclude the recording part of the lecture part. If you give me just a moment to do that, I'll do so wherever I put it. Oh my God, I think I lost it. I didn't record this. Oh, I am recording it. There I am. Oh my God, I thought we lost it. That would have been awful.